Hi guys, in this video we are going to talk about the organism Chlamydia trachomatis. Chlamydia trachomatis is an organism that is typically associated with sexually transmitted infection. But the reason we're talking about it today is actually because it is the leading cause worldwide of infectious blindness, which is also known as trachoma. So we're going to talk about it now. I'm going to talk about it in depth in this video, but later when we discuss a lot of the sexually transmitted infections, we'll review this one again. You've actually already talked about some of the organisms in kind of the chlamydia family. We talked about Chlamydophila previously when we talked about pneumonia. So you're going to see a lot of similarities with that I'll try to bring up as we go through this organism. Okay, so within the chlamydia family, you've got Chlamydia trachomatis, you've got Chlamydia psittaci, and you've got Chlamydophila pneumoniae. Chlamydophila pneumoniae and C. psittaci we actually already talked about earlier. They're causes of pneumonia largely. So this is kind of the only one that we're breaking out, but there are some things that it has in common. First off, these are all atypical organisms. And one of the things that makes them atypical is that they're actually an obligate intracellular parasite. Now, I say parasite not to tell you that this is some sort of strange, eukaryotic organism. No, this is still a bacterial organism. So it's prokaryotic, but it is a parasite in that it actually requires the ATP of host cells in order to survive. So I call it an ATP vampire or an energy parasite. So what that means for us is that we're not able to grow this organism in culture. This is one of only a few organisms that we talk about in medical microbiology that we absolutely cannot grow on our own. And this is one of them. So part of the reason for that is actually its kind of strange life cycle, so their life cycle relies on these things called elementary bodies. Elementary bodies are kind of like spores. They're not actually spores, but they kind of provide a similar function. They're resistant to harsh environments, to low pH, chemicals, things like that, and they're somewhat dormant, much like spores. And what happens is that basically this is the form of chlamydia that is able to survive outside the host cell, which is why they have that kind of hardy structure to them. So the elementary body is actually what's going to attach to a susceptible cell and then be ingested by the susceptible cell. Once it's inside the cell, though, now it needs to replicate, right? So it needs to stop being this spore-like elementary body and reorganize itself into what's called a reticular body, this RB here. So it reorganizes inside the phagosome. And once it becomes a reticular body, it actually can grow very effectively. So it will grow by binary fission over the course of 24 hours. Once it's finished growing, once it's made more of itself, it actually reorganizes back into an elementary body to get ready for its trip outside the host cell. So this is going to form an inclusion inside the cell. An inclusion is really just a collection of protein or some other structure within a cell that can kind of be visualized. Remember that from kind of your early readings in our microbiology. So it reorganizes now into an elementary body in preparation for leaving the cell. As the inclusion grows, it eventually kind of extrudes out of the cell, and that's going to lead to the cell kind of lysing and the elementary bodies being released. If there are any reticular bodies that are still present at that point, they're going to die because they can't survive outside the cell. Only the elementary body can. This organism is still technically considered a gram-negative organism. Sorry, I'm writing with my cursor today. I have a problem with my pen. So gram-negative, that's a little rough. But just remember, it's technically still a gram-negative organism because it just lacks that peptidoglycan that we really associate with gram-positive organisms. And there are a lot of different serotypes to this one. And the serotypes are going to be really important. So let's talk about that next. Okay, so C. trachomatis is a really important pathogen. And one of the things that kind of characterizes it is that it has several different diseases. The nice thing is we can characterize these diseases by their serotype. And there's actually a couple tricks to remember them. Okay, so the most important one to kind of keep in mind right now is trachoma. Trachoma is basically blindness. It's infectious blindness. Basically what happens in this case is that we get attack of the mucosal epithelial cells of the eye, causing blindness. The two other diseases that we associate are urogenital tract disease, which can actually lead to neonatal inclusion conjunctivitis and pneumonia. We'll talk about that in a minute. And then kind of a more rare, or at least not typically seen in the US, more seen in Africa and Asia, is lymphogranuloma venereum. Now, how are we actually going to remember this? There are lots of different serotypes, and you need to know your serotypes. Are we clear on that? That's why I have this VIS thing here. It's a very important slide. You have to know your serotypes. It's important enough that you have to know which pathogen, which serotype of the pathogen causes which disease. So this is pretty easy. ABC. ABC, blindness. So blindness, you know the B serotype leads to it, and the letter on either side, okay? I don't really have a good mnemonic for that one. Just remember ABC, all blindness, chlamydia. I don't know. Let's go with that. Then for lymphogranuloma venereum, it's all the L serotypes. So that's nice and convenient. So lymphogranuloma, it begins with an L. All the serotypes that are L serotypes, those are the lymphogranuloma venereum serotypes. Urogenital tract disease, those are all the rest of the serotypes. So D through K, that's everything to do with urogenital tract disease and anything to do with neonates, okay? So all blindness from chlamydia is A, B, and C. All lymphogranuloma venereum cases are L serotypes, and everything else is urogenital tract disease. Okay, so let's start out with trachoma. Trachoma, as I mentioned before, this is blindness, and it's caused by the A through C serotypes. So what basically happens is in trachoma is that you have these elementary bodies, right? And the elementary bodies are what are infective, kind of. So they're going to get into the conjunctiva underneath the eyelid here. And that's going to infect those cells there. And what we're going to get in response to that is a granulomatous response, because basically you've got these intracellular follicles that'll form. And when you blink, the follicles are going to scrape across the eye, and that's going to rip the cornea to shreds over time. It's also going to scar the underside of the eyelid, which you can see here. And what happens is, as we scar the eyelid, it kind of starts to invert, or sorry, the eyelid, it's going to invert. And that's going to lead to eyelashes kind of becoming stuck to the eye, and sometimes permanently so. Now, we all know what it's like to get an eyelid stuck in our eyes. It's uncomfortable, it's painful. Now, imagine you get an eyelash stuck in your eye. Your priorities are very swiftly going to change. Priority 1 stays the same, breathe. Priority 2, get this blasted eyelash out of my eye because it hurts and it's annoying and I can't see and my eye is watering. It's a big problem. So suppose you had a disease where you had maybe 4 eyelashes in your eye 24 hours a day for years. So in the first image here, I'm basically showing you the normal, okay? We've turned the eyelid over so you can see the large, deep lying blood vessels that mainly run vertically, okay? And it looks nice and smooth like glass so that it can move over the globe of the eye without causing any sort of discomfort. Then as we get infection, we get kind of this follicular inflammation here. You can see the follicles forming in the upper tarsal conjunctiva, also shown here. And there's this pronounced, intense follicular inflammation. So we're going to see the thickening that's happening here. And then we get trachomatis scarring. And that's really what we're showing up here, where you have the presence of this early visible white lines of scarring. And it's starting to obscure the vision, as you can see here in the eye. At this point, you're going to get trachomatis trichiasis. What you see here is you see at least one eyelash that's rubbing the globe of the eye. And it basically is evidence of the recently removed interned eyelashes. And then finally, the result is corneal opacity. This is presence of really easily visible corneal opacity, and obscures at least one part of the pupillary margin. So in early trachoma, you've got this intense inflammation, neovascularization. The visual field is still clear, so the patient can see at that point. But in later stages, the inflammation and neovascularization crosses the limbus, and then by the end, no visual potential is left in the eye. The cornea is scarred, no light gets through. You can see the eyelashes rubbing across the eye. So it's really, really difficult. So how do we get it? If a person has trachoma, their eye hurts. It's bothered. Just think of that eyelash in your eye. So you're going to scratch it. You're going to rub your eye. So they scratch it, then they come by you and they shake your hand, and then let's say you scratch your eye. Now you have it. So that's one way. The other way, the more difficult way, eye-seeking flies. So think of it this way. Most of us living in, Chicago, we see a fly, we just kind of swat it away, okay? No big deal. In some parts of the world, there are about 10,000 flies per person. So they're busy doing other things with their hands. They don't want to have to spend their whole day swatting away flies because they need to do things like make food, provide, go to work. So they're busy. So, and the fly doesn't hurt. It's just a bother. It's irritating. Well, what the fly wants is something very different. See, this film on your eye, it's sweet to a fly. Flies love eye film. It's like delicious milkshake to them. So the fly lands on it, and they like this salty, savory, sweet film on your eye, and they take a little drink. And while they're there, their little feet are touching the surface of this person's eye. And what happens is, as they fly away to the next eye, they bring with them on their feet the elementary bodies from this eye. So their feet actually pick up the elementary bodies, bring it to the next eye, where they take another delicious, salty, sweet sip, and they deposit those elementary bodies. Pretty gross, right? But that is how it works. This is a chronic disease, but it's so easily curable. A single dose of azithromycin 1 time per year will completely wipe it out. But worldwide, it is still the leading cause of infectious blindness. Okay, so not to forget the other things it does, let's talk about the non-gonococcal urethritis. Non-gonococcal, all this means is that this is urethritis that is caused by not Neisseria gonorrhea. That's it. So it's chlamydial urethritis, but we call it non-gonococcal, which should tell you something about the prevalence of gonococcal urethritis, but I digress. The serotypes for this are D through K, all right? Women are typically asymptomatic. We don't tend to show any sort of symptom with this, but that's actually worse because even though there is no actual symptom, that doesn't mean there isn't damage. It just means that we aren't feeling it and going to a doctor for treatment. And the end result of that can be very severe. Salpingitis, endometritis, pelvic inflammatory disease, and in some cases, sterility. Men get symptoms. They're going to get a nice urethral discharge here, dysuria, pyuria. They're going to seek treatment. It's the women that don't. So obviously there are some significant effects on women's health for not getting treatment if they contract non-gonococcal urethritis. But the other people that might be affected by this are babies coming through the birth canal. So as a baby comes through the birth canal of an infected mother, they actually pick up the elementary bodies. And one of the places they first pick it up is, once again, those eyelids. So we need to kind of think of this in 2 different pots, right? So when we talk about trachoma and infectious blindness, we're talking about serotypes A through C. But when we're talking about neonatal conjunctivitis, we're talking about serotypes D through K, because you have to think about the transmission path. So neonatal conjunctivitis comes as the child comes through the birth canal. And the types of chlamydia that infect the area near the birth canal are D through K. So what's going to happen is about 5 to 12 days after exposure, the infant's eyelids are going to swell and hyperemia occurs, and you get this copious, see this glue-like purulent discharge that's coming from the eyes. If you only treat this with topical therapy, what happens is the baby kind of like rubs at his face and gets it into his respiratory tract, and that leads to pneumonia, which is really dangerous, obviously, for a brand new little baby. So for this reason, when we're talking about neonatal inclusion conjunctivitis caused by chlamydia, you do need to do oral therapy, not just topical therapy. So don't treat it topically, treat it orally when we're thinking about little babies, okay? Okay, last one. This is lymphogranuloma venereum. We don't really see this in the United States. It is a chronic sexually transmitted form of C. trachomatis. We see it more in Asia, Africa, South America. So basically what happens is this is an ulcer node disease, which we learned about a lot back in host defense, host response. I think we talked about it with like Francisella, some of the other infections around there. But basically you get kind of a small ulcer, a small painless ulcer at the site of infection. That's pretty much overlooked during the primary stage of infection. And since it's overlooked, patients progress to the secondary stage. And this is what the secondary stage looks like, where you have this massive lymphadenopathy. It's painful, the nodes are swollen, you might wind up with elephantiasis, fistulas, and basically just these extensively swollen inguinal lymph nodes. It can be treated, which we'll talk about in a minute. And remember, it's those L serotypes, okay? Okay, so now that we know all of the particularly unfortunate things that C. trachomatis can cause, let's talk about treating it, preventing it, controlling it, things like that. To diagnose it, remember, this is not an organism that can be cultured. We're not going to culture it. That's not the gold standard anymore. So you need to do cytologic, looking for those inclusion bodies in the cell, or serologic. Serologic is actually probably your better way of going, even though it's going to take a little bit. Even better would be either PCR or direct detection of the antigen using either immunofluorescence or ELISA. So it's actually fairly easy to diagnose, even though we can't culture it. Treatment, prevention, all of that. For ocular and genital infections, azithromycin is a good choice. So is doxycycline, and it only takes about 7 days. For newborn conjunctivitis and pneumonia, you might go down to erythromycin, and you're going to treat for a little bit longer. Lymphogranuloma venereum, doxycycline tends to be recommended, but remember there are all those people that doxycycline is contraindicated for. So children, pregnant women, other patients for who, whichever reason doxy isn't a good choice, you're going to move to erythromycin for those. Okay, so what are the take-home points for C. trachomatis? First off, C. trachomatis, you got a couple different serotypes that lead to 3 different diseases. So A, B, and C, we're talking blindness. D through K, we're talking urogenital conditions and neonatal conditions. L serotypes, we're talking lymphogranuloma venereum. For trachoma, which is the cause of blindness, remember, we can get that from those eye-seeking flies or from fomites or fingers, where we touch the elementary bodies and then touch our eyes. For neonatal conjunctivitis, remember, it's a D through K serotype because you get it as the baby passes through the birth canal, and we're not treating it topically like we would the other causes of conjunctivitis. We have to treat it orally to avoid pneumonia. Thanks for watching.